Julie, one of the major trials that I think we're all interested in is the Maya trial, which was a comparison of daratumumab, lenalidomide and dex versus lenalidomide and dex. What are your thoughts on that trial in terms of how well that combination works, and what are some of the downsides of that combination?
I think as of right now, it looks like a very impressive triplet combination. The addition of daratumumab looks like it's adding about 6 months in progression-free survival, which is quite impressive for this non-transplant eligible population. I think that you need to choose your patient population carefully because it's not without side effects. One of the bigger ones, and I know that we were talking about this earlier today, was the risk of infection, the neutropenia and the pneumonia. And I don't know, Paula, you have more experience with using daratumumab if you want to comment on what you guys do.
Yeah, so first of all, I agree. It's probably one of the combination that we are all very excited about. We're not sure if we can translate immediately in our Canadian landscape, but knowing that in patients, even elderly, above 65, where the addition of daratumumab can really extend so much the PFS of this patient, knowing that response rate goes up to more than 90%. You can get more than 45% of complete remission, MRD negativity. These are all elements that for us as a physician and for a patient, I would say they're extremely important. So extremely excited, and of course the longer follow-up will hopefully will give us also an overall survival we're looking for. But you're right in the sense of the side effect. We all look at the number, we want to see great survival plateau line that show how this response actually lasts. On the flip side, though, we have to carefully select the patient because it is a 20% risk of infection, and I would say, pneumonia, lung infection, I'm thinking, and including also neutropenia. So these are factors we have to consider. I can tell you in Alberta, for example, we are proactive on using G-CSF, so we never really hesitate if the patient even cycle 1, day 1, have a neutrophil count 1. We don't wait. We just right away use G, for example. Antibiotic is something if patients have repeated infection, we try to be proactive on using it. But I'd like to hear from you, Darrell. What is your experience, and of course, what is your way to?
Very similar. I think it will be a game changer in the Canadian landscape in terms of the way we treat patients, and I think it eventually will be one of our first line opportunities anyway, assuming regulatory and reimbursement happen. One of the interesting things, though, I think from that trial is that the control arm of RD looks better than it did in the first trial when that was run. Yeah. So, what your thoughts are on that?
I suspect a couple of things. One, it's a clinical trial, and I think that we've all gotten much better in using Revlimid and dexamethasone. We have a lot of experience, and so even people on the control arm are going to do just that much better. Probably a little bit of patient selection as well. But I agree. I think that it was an impressive, compared to the first trial, an impressive benefit in just the RD patients, and the adding daratumumab just seemed to magnify that so much more.
Yeah, I think for both groups of patients, it was a very good result.